We are going to talk about headaches, concussion headaches today. So headache tends to be, I was saying in the previous one that I believe I lost connection, headache is one of the most common symptoms that people experience after concussion. And so one of the questions, hi there, let me know if it stops or because something froze on my end. So basically headache is one of the most common symptoms we experience after concussion. Up to 90% of people experience them, and they'll experience them for longer than 3 months. The breakdown with post-traumatic headache tends to be migraine and then sort of a musculoskeletal, cervicogenic or tension type. And so cervicogenic means it's originating from the neck, it's originating from the cervical spine. And one of the ways we can think about that is whiplash disorder and concussion look very similar, and they happen at overlapping G forces, at overlapping acceleration, deceleration forces. So when you take a hit to the head, whether that's in a car accident, whether that's on the ice, whether that's on the field, your head kind of has to whip around for a concussion to occur. And that whip has to happen at 5 Gs to sustain whiplash, 4.5 Gs to sustain whiplash, but it has to happen at more than 70, more than 80, more than 100 Gs to sustain a concussion. So if you've sustained a concussion, you've exceeded that 70, 80, 100, up to 160 Gs of force. So you've definitely met that 5G criteria for whiplash. And when you look at whiplash and concussion on paper, like if someone came in right now with whiplash and I was only going off of symptoms, it would be almost impossible to tell them from a concussion patient. So there's some exams we do. There's joint position error testing, the smooth pursuit, neck torsion testing, different things we can do to look at, is this coming from the neck or is this coming from the brain? But so regardless, when you're looking at concussion or when you're looking at whiplash, you've got to understand why the headache, why the dizziness, why the symptoms are occurring. And it's this paradigm of the brain. The brain is all about sensation, integration, and then an output. So it senses something, it integrates that information, says, what is this? What do I want to do with it? And then there's this output. And so like if I'm drifting over to the left, my brain feels it, that senses it. It integrates, hey, I don't want to fall to the left. And the output is to bring me back up to the right. So for some reason, after a concussion, after that head whips back and forth, the sensation, integration, and output is headaches due to muscle tension, due to altered ability to inhibit pain, things like that. So the systems we look at in headache and the systems that we kind of look at in whiplash are a lot of things, but what we're looking at, particularly for the paradigm for headaches, is we're looking at vision. So our eyes, what we see in the world, our vestibular system, kind of the system that tells us if we're moving. It's the system that's kind of out of whack in like BPPV, when you feel like you're spinning, but you just rolled over in bed. And so you got your vision, your vestibular system, and then you got your proprioceptors, or your joint and muscle receptors that tell you where you are in space. It's what lets you know, like, I know my arm is bent, I know my head is turned to the right, because I can feel it even if my eyes are closed, right? So that proprioception, that typically up in the higher neck, kind of vertebrae C1 to C3, there's densely populated with proprioceptors, and when that gets whipped around, those proprioceptors don't give accurate feedback to the head. But the problem is the head has to integrate what I see with what I feel in my ear, with what I feel in my body and my neck. And if those signals are mismatched, you get head tilts, you get dizziness, you get brain fog, you get headaches, right? So the information from the visual system, from the vestibular system, and from the neck has to match up. So when people ask, can I just stretch? You're only hitting one of those systems, and you might not even be hitting it properly, right? So you're only hitting this proprioceptive system. I feel my neck getting stretched, and oh, that feels good, but the headache comes back. Or the headache never went away. It's just this kind of temporary, it's like scratching an itch kind of thing. So when you have this mismatch, you get tight muscles, tight neck, tight, like headaches, head tilts, whatever. So the idea is that the spindles and the joint receptors and all this proprioception has to match the ear, has to match the vision. So when you're looking at rehab, the rehab needs to be active, sort of active and passive. Passive being soft tissue, adjustments, things like that. But active in terms of you need to strengthen, stabilize, improve proprioception, and we'll talk about all that now. So one thing that I like, Dr. Cameron Marshall, concussion doc, actually did a video. I think it was one of his either his last couple podcasts was actually talking about concussion as well. So you'll hear a lot of the information repeated in his podcast as you would hear here. But basically the idea is the rehab needs to decrease the noise, decrease the fuzz between the vestibular, the visual, and the proprioceptive systems for you to decrease your headaches. And so one of the things to think about, the Dr. Cameron Marshall concussion doc mentioned that I really like, as an MD, I like to integrate. And he says you can't like isolate the treatment. So if you're thinking about vision, vestibular, and proprioception, you can't just work on one. You can't just work on the proprioception. You can't just work on the vision and say, oh, like after I do the vision training, then I'll do the proprioceptive stuff. Or after I do my vestibular rehab, then I'll see the massage therapist. It doesn't work that way. You need to integrate. And so one of the things that is really helpful is finding a concussion specialist, someone like myself, someone like Dr. Marshall, someone like Dr. Nathan Kaiser, someone like Dr. Paul Herkel, docs who do concussion, because we can at the very least give a baseline, a little bit more in our specialties, but give a baseline, a broad base of proprioceptive, visual, vestibular work. So one thing to also consider is that post-traumatic headache tends to also be associated with anxiety, depression, PTSD. So not things sort of that fall outside of the realm of overt vestibular, visual, proprioceptive feedback are cognitive behavioral therapy, mind-body medicines, things like that. Totally within the realm of very helpful for headaches. So bringing it back, one of the things to think about is passive feedback is going to be good, but only for a short amount of time. It's going to decrease symptoms. You're going to feel pretty cool, but basically one way to think about it is if I go back here and I work on the suboccipitals and I work on these paraspinal muscles and the sternocleidomastoid, and I do things because your head whipped and these muscles got tight. If I go in there and I just work on those and I send you out into the world, you might feel better for a little bit, but it's going to come back because your brain is always trying to keep you upright, trying to keep horizon level. So if I change the signal, but nothing cortically, nothing in the brain has changed, the signal is just going to kind of come back. And you're going to come back with the head tilt or the tight neck or the headaches. So you really need to integrate. You need to bring strength and proprioception into it. So some of the soft tissue methods that I really like, that I will be doing, kind of the helpful stuff, the practical stuff that we can do in lockdown and quarantine and at home. I'll be posting some reels and some TikToks. So if you're on TikTok, I'll post there. If you're on Instagram, which you're watching here, I'll be posting some reels where I will show you how, if you've got a lacrosse ball, if you've got a butter knife, my fancy tool, oops, I zipped it up. Looks like this, but a spoon or a butter knife would work. But late for my own suggestion. That's all right. I'll post a recording later. But lacrosse ball, baseball, tennis ball, butter knife, kitchen spoon, resistance band. I'll show different things that we can use for sort of the soft tissue aspect and how we can tie some proprioception into that. But basically the soft tissue methods that I like ART. I really like Stecco. I've got the posters on the wall. One cool thing, Stecco's got a published study where they took participants with whiplash disorder and they gave them one Stecco treatment, so a 30-minute treatment every 5 days for 2 weeks. So there was 3 treatments in 2 weeks. And then there was the control group was told mobilizations and stretches and some of the things that I might show you here. And they did it 5 days a week over 2 weeks. So they had 10 sessions versus 3 sessions. And the Stecco group got 14 degrees more range of motion than the 10 treatments alone. So there is something to manual therapy. And I love Stecco. One of the things you can also combine it with is something really cool like the Electrons Plus guided PEMF unit. There's some great results that you can get pairing ART Stecco with this guided PEMF electric charge, which is pretty cool. So some of the soft tissue stuff really works on the muscle spindles, really works on I don't want to get too technical here. It just kind of works on the muscle, works on the feedback up to the brain, and when things like ART, where you get this sort of active component to it, it sort of gets the brain involved in that feedback, which is sort of proprioceptive, which is cool. Other things to consider: physical therapists, chiropractors, osteopathic physicians will do HVLA adjustments, high velocity, low amplitude adjustments, crack your neck or crack your joints. Really actually super cool and really low risk. So people who are scared of kind of getting their neck turned and popped, really low risk. If you're working with a licensed physician, they'll run through all the risk factors in their assessment to know whether you're even a candidate for adjustment or not. But what's really cool is that little pop, that little cavitation. It's a ton of feedback up to the brain from the joint mechanoreceptors and from the muscle spindles in the neck, especially up high, C1, 2, and 3. So when you get that feedback, it decreases, or it literally changes the map in the brain. We've got studies where after adjustments, like brain connectivity changes. So what's cool is if you've done some soft tissue, you've loosened up the muscles, and you still got this stuck joint that's causing decreased signal, decreased afferentation up to the cortex. You pop it, get that motion back, and then we do something proprioceptive and we keep that motion. A lot of people will get an adjustment and they're like, oh, I gotta, I don't want it to go out of place. I'm never gonna move again. And then you get stuck. The point of the adjustment, the point of the manipulation is to improve motion. So if you get an adjustment or you get a manipulation, move. That was the point. It was to help you move. So that's kind of cool. So soft tissue ART, Stecco, really cool therapies for mobilizing sort of the fascia. You can work with nerve entrapments. So if the suboccipital muscles are really tight over here, you got pain radiating down one side of the face. Really cool stuff. Chiropractic adjustments are great for that as well. There's also some good research on acupuncture or dry needling to kind of disrupt the muscle spindle. Acupuncture and dry needling, two totally different things. So traditional Chinese medicine, Eastern medicine, acupuncture is working along meridians and things that I don't understand because I wasn't trained in it, but it's this deep, beautiful system of medicine. Dry needling is very crude and just kind of poking the muscle, disrupting the spindle, and trying to get the muscle to relax. What we're doing in dry needling from a TCM perspective, we could be fucking it all up. We don't know what TCM is thinking. It's a beautiful old system that has lasted this long because it's doing something right. And dry needling is just kind of looking at the muscle. We might be disrupting some chi or some TCM stuff. So I don't know what to make of that, but there's some good research on it. You can work on the suboccipitals, the SCM. Got to watch for the carotid here. So don't go sticking needles in yourself at home, but find a practitioner. So that's kind of the passive stuff. The passive stuff would be your soft tissue, your adjustments, your acupuncture. The active stuff is we really want to build stability and strength within the neck because we want some stiffness. I haven't seen the study myself, but Dr. Cameron Marshall was talking about how basically you'll drop weights on mice heads to make animal models of TBIs will drop a weight on a mouse's head, but not enough to crack the skull, but enough to create a mild traumatic brain injury. And what they did is they stabilized the neck, so the head can't move at all. And when they do that, you just could not concuss a rat because there wasn't an acceleration deceleration. So the more kind of stiffness and not so much the strength. It's not so much I got this big meaty neck that I can do like 600-pound head flexions. But it's more about the stiffness that you can create and how quickly you can create it. Being able to react to that ball flying at your head or being able to react to the guy coming in to give you a body check on the boards. Being able to create stiffness really quickly can help kind of protect the brain. And we know that reaction times are decreased for up to 60 days after concussion. So getting that rehab in, getting that reaction time in. There's cool tools like the Iron Neck, this massive tool that comes in on your head and lets you work full 360-degree range of motion. but you can set it up to a resistance band or a cable column so that you've got resistance while you're doing cervical range of motion drills. Very cool for improving kind of functional strength in the neck. My favorite tool, because I talked a lot about, in the beginning, I talked a lot about your visual system, your vestibular system, and your proprioceptive system. Well, the motion guidance mat and the motion guidance tool that I use, I've got different mats. I've got one that looks like a maze. Let's see if I've got it accessible. So I've got this one here that looks like a maze. And so you'll start, this is the top. So you start at the beginning of the maze, and by working your way around, you get a laser on your head. And so you kind of start at the beginning of the maze and you work your way around, and you end up wiggling your neck through full range of motion as you're doing that maze. And what's cool is you get the visual feedback the whole time. So you know, like, you're being able to match your visual system, you're seeing the laser, with your vestibular system, your head is rotating, and the proprioceptive system. I feel like the laser should be here, but I see it over here, so I've got to correct that. And it's syncing all these systems together. So it's not necessarily improving a ton of strength, it's not necessarily improving a ton of stability, but it's bringing in that visual, vestibular, and proprioceptive systems all at once. And one of the ways that we can test if this is actually helpful and test kind of the solidity, the plasticity, like did this last. It's called the joint position error test. And so what we'll do is we'll have kind of the laser straight up in the center of the mat. I'll have you close your eyes, take it all the way to the right, and then I want you to come back to center, what you feel like is center. And what you'll see is that people will be way off to the left, or way high, or way low, because they can't actually feel what it feels like to have their head in neutral. So we try it again, and we try it again, and being able to correct and say, oh, I was a little bit high, this is what it feels like. That's where it feels like, I'm going to try it again. Okay, this feels like where I was, cool, I'm accurate. And we practice that, and so it's building the kind of the proprioceptive feedback individually, but you can tie it in with some of the visual feedback. It's a really, really cool tool. I like it a lot. They've got some home kits for people to buy. So that is that. So when you're looking at kind of the grand summary of post-concussion headaches, a lot of them tend to be migraines. That can be a completely different talk because that's a completely different animal with cortical spreading depression and all this kind of stuff. So it tends to be post-traumatic headache, it tends to be migraine or tension type, cervicogenic, kind of coming from the neck, coming from muscles and aberrant feedback between your eyes, your ears, and your neck. And that happens because in concussion, to even get a concussion, your neck has to move, because remember, if it's completely stiff, you can't concuss. So your neck has to move, and whiplash happens around 5 Gs, concussion happens around 70 or more Gs. So if you've had a concussion, you've probably had whiplash. And so you're messing up this cervical kind of musculoskeletal feedback between the eyes, the ears, and the neck. So to rehab that requires some soft tissue, maybe requires some adjustments, might require some acupuncture, but some passive therapies to improve kind of the tissue quality through here, to improve the range of motion possibilities. But then you've also got to take those possibilities and solidify them into, I own this range of motion, I own this movement, with things like the iron neck or strength exercises, isometric exercises to improve the strength through here. But then also visual motion guidance feedback, where you're getting to see, where you're getting to see your head and how that feels, and you're getting the actual real-time feedback of like, what is my head doing in space? And when you can improve that, the ultimate thing is you're improving feedback to the brain. The brain is now, all these systems are online. The vision is matching the ears, is matching the neck. So now this muscle doesn't have to be so tight, because it knows where neutral is, and it knows that it doesn't make sense to crane the neck down this way. It doesn't make sense to pinch the nerves in the back of the head. It doesn't make sense because the signals I'm getting don't say to do that. So the idea is to kind of rehab from that perspective, not just going, oh, this stretch feels good, but then it doesn't last, right? So that's kind of the big wrap up. I will be posting, like I said, I will be posting some at-home soft tissue mobilization, soft tissue things. So in the meantime, while you're waiting for those, I'll try to post them. I'll try to post one for kind of the front of the neck. So there's a muscle down here, subclavius, platysma, sternocleidomastoid. So I'll try to post for kind of the front, and then I'll show you some stuff to do for the back. And for these upper traps, levator scaps, things like that. So I'll try to post several that might break into 3 to 6 different reels, but I'll try to post those over the next week. So in the meantime, what I was going to say is in the meantime, you don't have to have a fancy fascial tool like this. You can use a good hardy kitchen spoon or a butter knife, not the serrated side of the butter knife, but you can even use the handle or the opposite, not serrated side of the butter knife. Use with lotion. And then if you have a lacrosse ball, a tennis ball, a baseball, something like that, that's really all you'll need, and we can do a lot of damage, good damage, but a lot of damage on sort of these muscles to improve that proprioceptive feedback and improve the tissue quality. But again, you're going to want to build some strength, and you're going to want to improve on that proprioception after you do this. This can just provide some relief and some gains from home, so you're not just like struggling with headache and trying to figure out which medication works, because yeah, that can be a pain in the butt. So if you have any questions, again, feel free to send me a DM.